Thank you for inviting me and allowing me to give some perspectives of what is going on with healthcare in terms of homelessness and current economic and other changes. First, I want to say that I don't think from my perspective as an emergency physician at Hennepin County Medical Center that I'm going to be able to give you hard data, but I'm going to give you observations that myself and my colleagues have made over the last 18 to 24 months, and particularly maybe the last 6 months. I'm going to first say that there's absolutely no doubt in my mind, and in anyone who I know, that our healthcare system requires reform. It was disgusting, and it was almost disgraceful the way that healthcare options were available to people, and to tie healthcare with jobs was an inappropriate method of delivering good quality care. I also want to qualify that to say that I think our health care in the United States is excellent. The care that we can provide people is just outstanding. It beats every other place in the world. But the problem is getting it equitably to others and to everyone. So with that in mind, I'm just going to mention a few things we've noticed in our emergency department. Traditionally, we've had about 1/3 of our patient population who have insurance of some sort, 1/3 who are calling themselves self-pay, which means they have nothing, and then we have 1/3 who have some sort of financial support from a public program, Medicare or Medicaid. I think this has been stable for several years at Hennepin, although we don't have more recent statistics for the last couple of years. One of the concerns that many people have expressed in the literature, in editorials, and in the media is that emergency departments are being inappropriately used by people who don't have insurance. And I'm here to say that I don't think that's the case. For one thing, there has been a recent publication out from the CDC. Every so often, they will analyze who is using emergency departments and what are the characteristics of this patient population. The most current one was just out this month, and the name of it is Emergency Department Visitors and Visits, Who Used the Emergency Room in 2007. So they're kind of a few years late. But some of the findings that I think are pretty remarkable have to do with, obviously, the emergency room use varies with race and ethnicity, with age, and with family income in a predictable fashion. You can imagine what this is saying. But it also stresses the fact that people who come to the emergency department with Medicare or Medicaid coverage are just as sick as people who are presenting with insurance. So the acuity of those patients is equal. They're not coming for trivial problems. To me, that suggests that there's a gap in the way in which we are able to establish primary care for these people, but when it comes to emergency department use, they're not being abusive. They're not overusing the ED for trivial problems. They're coming here for high acuity issues. Or, on the other hand, it could mean that those with insurance also use the emergency department for trivial problems, and therefore the acuity of both groups are the same. When you think about, when I think about patients who have no insurance or who have public insurance and have to utilize the emergency department, the thing that becomes really apparent is barriers to care. For instance, I have a cousin who is schizophrenic. She's very stable. She's been very compliant with the medications. She does everything her doctors tell her to, but she doesn't drive a car. So for her to get to the hospital to make one of her clinical appointments takes 4 hours one way by bus. So she does it, but when she doesn't feel good, she doesn't. Because who wants to be on a bus for 8 hours for an appointment? So this is just a real, really specific example of one particular barrier, which is transportation. Another thing, of course, is the fact that patients who don't have supportive housing or don't have stable housing tend to have problems that are very predictable simply because they don't have a place to stay. They get exposed to the sunlight and therefore develop complications of that. They're exposed to tobacco and other types of fumes that make their chronic illnesses worse. If I could pick a few pathologies to target for patients who are homeless, I would say their eyes, their teeth, and their feet, because those are the things that make a difference in how they process their daily life. Let's see what else I wanted to say. I think there's been a lot of evidence that supportive housing has reduced emergency department visits substantially. And again, I think it's because once patients have an organized life, and that could be something as simple as a place to stay that night, they're able to attend more specifically to their own needs. Lots of solutions have been advanced to circumvent some of the problems of emergency department overuse or abuse. Almost all of them involve novel techniques to change, that require the change of culture. So for instance, opening clinics at night instead of daytime hours, opening clinics in places not specifically associated with the hospital, rather in the community, having community clinics based in homeless shelters is another option that has been advanced that makes a lot of sense. Or having roving clinics where people go on the street corners and meet the people who need care. So with that, I think those are my main observations. I do know that over the last several months we have seen an incredible number of people who come to the emergency department who have elected to buy food instead of medicine, or who have recently lost their jobs, therefore they've lost their insurance, therefore they haven't taken their medications for several months because they can't afford it. Had those things not happened, they wouldn't be as sick as they are that day, and probably wouldn't need to come in for emergency services.
Thanks very much.